All right. Well, welcome and thank you for joining us here today. I wanted to speak with Chad Cook about his most recent paper entitled Five Recommendations to Address the Limitations of Patient Reported Outcome Measures. And the paper was published recently in December in 2021 in JOSP, JOSPT. So, Chad, I know you are a part of CEMMT. You may have to explain that a little bit more, but could you tell us a little bit about yourself and your current role at Duke and a little bit of background as an internationally recognized researcher?
Sure. Thanks, Megan, for having me on. Indeed, I'm part of CMET, or the Center of Excellence in Manual and Manipulative Therapy at Duke. And the center is really built around providing accurate information on force-based manual therapies. And we have a nice website, social media sites, podcasts, and blogs. And soon we'll have living systematic reviews to update the clinicians. I am a researcher at Duke. I specialize mainly in outcomes research. I've done a few trials, do a lot of database exploration, and have done some manual therapy research too, although that's not the largest amount of research I've done. I think primarily patient-related outcomes is probably the area I've done most research in.
That's great. Thank you. And so this current paper that I want to talk to you about is really not a clinical trial at all. Instead, it was a viewpoint. Can you describe a little bit about what's different between the viewpoint versus a traditional peer-reviewed paper?
Yeah, I'll be glad to. So in 2015, JOSPT started publishing viewpoints, which are about 1,500 words. A lot of people would think they're similar to a white paper. So it's an evidence-based white paper where you take a controversial stance on something and then support it through references, through good critical discussion. And it's designed to make people think. So I have actually been involved with JOSPT on the viewpoints since day one, since about 2015, and decided to write one myself and toss it in JOSPT. They are peer reviewed by typically three individuals. So from start to finish, it changes quite a bit. But the nice thing, the viewpoints are fun. They're easy to read. They're short. They touch on things that you may not normally touch on in a typical peer-reviewed manuscript, and they're, I think, a lot of fun.
Yeah, no, it's a really easy read for those who have had a chance to look at it. This specific paper actually has a really nice infographic as well. So I'd encourage you to take a look at that. So I want to ask you a few questions if that's all right. And I want to ask first, what prompted you to write about limitations of patient-reported outcome measures?
Yeah, so I think, I've heard it said that people think that patient-reported outcomes or PROMs are biblical, right? That the data you get from them is completely error-free, and that it directly tells the status of a patient. And I think it's really important that, we invest a lot of time in the interventions piece, and then we measure it with typically the patient-reported outcomes, but we never really bother to look at whether those outcomes truly measure what we think they're measuring. So I wanted to write a viewpoint to just discuss some of the limitations of those outcomes measures, because I know a lot of the clinicians have seen an incongruence between the changes they're witnessing in the patient and what maybe that patient is putting down on an outcomes measure. And there are reasons for that. And certainly it's not a perfect tool. It's certainly not biblical, is what I've heard said.
Well, haven't you published quite a bit on outcome measures in terms of their validity as well previously?
I have. So my earlier part of my career, I actually have created 4 outcomes measures from scratch, created our own scales that are built around either quality of life or activity limitations or things like that, but have done item response theory validation, classical test theory validation. We've just looked at outcomes and how responsive they've been in certain studies. We've looked at relationships between physical performance measures and outcomes, done a lot of different types of research. So I'm pretty well versed in outcomes. It's always been an interest of mine. I've always felt that if you are going to measure something, let's understand what you're measuring or what that measurement tool tells you. And it's been eye-opening.
Yeah. So in the paper specifically, you use the word term legacy measure. And what does that mean? And are you being derogatory towards these legacy measures?
Yeah, actually, people have accused me of being derogatory by calling them legacy measures. And all it is these are measures that have been around a long time. So these are the standard go-to measures. Like, for example, for low back pain, we would typically think of an Oswestry or Roland Morris. Those are legacy measures. They've been around forever. They were created, 20, 30, 40 years ago. And we've adopted those into clinical practice because they've been considered the best tools for use. So when we say legacy measures, they're typically created quite a while ago. They've been used a long time in clinical practice. They typically populate most of the research studies that we review, and it's not derogatory whatsoever. Some of the legacy measures that have been created are actually really good measures, some not so much.
Okay. So in this recommendations paper, you actually outline several limitations of outcome measures, in which some of the limitations that you outline, which one do you think are the most worrisome?
Yeah, so I guess, I mean, it's almost the simplest ones, but face and content validity, I think. Uh, in other words, face validity wise, do the patients actually understand and associate to what they're scoring? Does it actually accurately capture what we think that we're capturing? And with content validity too, does it capture all the constructs of a person's health status or recovery or their report of change or all of those elements? And what's interesting, the literature suggests that content validity is the area that is least studied in these outcomes measures. And you would think that that would be like the automatic, the one that you would do first. But in most of the legacy measures, they lack content validity. So this means that there may be a disconnect between what we think we're capturing and the actual patient and what their thoughts are, and maybe a disconnect between all of these constructs that we think they're assimilating, but in reality, they're not. To me, that is kind of a kick you in the teeth type of thought. But it's certainly those two, the bare bones, those two for sure, I think are probably the most important.
And I think that probably maps on really well to what we hear in the clinic, right? Clinicians saying that their patients don't feel like that this form represents, what they feel or what they think. And so I think that that's spot on. How much of the error or variation in outcomes do you feel is associated with the weakness of an outcome measure?
Yeah, I think it depends. So, and when we mean by error, I think it's important that the listeners understand that all tools that we use to measure have error, right? A goniometer, and we taught our students how to use a goni, right? We say there's about a 5-degree error on this thing. Even more sophisticated tools like digitized imaging of spine movement. It has a certain amount of error in it, but typically has a low level of error. And especially when you compare to something like body markers, where you put light emitting diodes on skin, and you're assuming that you're measuring joint related movement with that. There's quite a bit of error related to that because there's skin and fat and a number of other structures. So it depends. It depends on the tool, but generally what I've heard said is that there's about a 20% error on these tools. So if you're attempting to capture 100% of whatever construct you're looking for, there's a minimum 20% error where it's not going to accurately capture that in that particular population. It may be higher in a patient population in which the tool doesn't really mean anything to that patient. And you mentioned earlier that, that disconnect between
Right.
clinicians and patients. And there are actually many studies that have looked at this qualitatively, that they've actually asked patients, does this mean anything to you? And the patients are like, no, this doesn't really reflect, something that is similar to my condition. But yeah, I think about 20% is probably a good place to start with respect to error.
So as we talk a little bit about error, I'd like to transition a little bit into the MCIDs that you talk a little about in the paper. And can you talk about the limitations of the MCID that you discussed?
Well, I mean, I'm guilty of bashing the MCID for about 15 years, and there are so many limitations. First of all, we're assuming that a single point or a single point of change is going to be reflective of all the patients that we see. So, for example, a 9-point change on the ODI is going to be a meaningful change, a clinically meaningful change for all patients that we evaluate. We know that that's not true. We know that that value, that MCID, is different depending on the level of severity of the individual, depending on the sex of the individual. We know that it's different depending on how the MCID is calculated. And there are 5 different ways that the MCID is actually calculated. So depending on that, that's going to give you a completely different number. It depends on whether it's anchored to an external score. It depends on whether it's distribution based. It depends on whether it's consensus based. I mean, the MCID is, I think, the biggest hoax in outcomes right now. And my biggest concern is that we're turning around to third-party payers and saying, well, they made the MCID, or they met it, or they didn't meet it, which shouldn't influence pay for performance, when in reality, the consistency of that MCID across the patient population is very questionable. I really struggle in looking at a within session measure of change in a certain amount on the outcomes, in which outcomes I think don't really necessarily reflect that treatment effectiveness. So I really struggle with that, and I will continue to struggle with it. And I will continue to kick the MCID even when it's down, because I think it's something we've gravitated to because it's simple, but it's completely misleading.
Yeah. And so you mentioned that the outcome measure may not specifically reflect the individual's personal experience. And can you give an example of this?
Yeah, I mean, this is really important too, because I think if you actually had a chance to sit down with your patients and say, you just filled this document out, what are your thoughts on this? I had frozen shoulder about a year and a half ago, and I went to the physician's office because I struggled with it about 6 months, and I did all my things, kept lifting weights, I kept grinding through it. And it was getting to the point, I don't mean to be a baby, but I was like 8 out of 10 pain. I mean, this thing couldn't sleep, hurt all the time. And I said, I gotta get this done. So immediately when I get into the clinic, I go into the room and they have me complete a PIN shoulder scale, right? I'm familiar with the PIN. We've used it in a number of different studies. So I'm sitting there and I'm filling out the PIN, and I know about outcomes measures. I know what they're supposed to consist of. I'm familiar with the PIN, and I'm like, not relevant, not relevant, not relevant. That one's kind of relevant. That question's not relevant. So I'm going through and I'm filling this out knowing that how I'm scoring it is not really relevant to what I was going through with my frozen shoulder. I should have had pain related questions, because I was pain interference questions. That's what I was struggling with, not a bunch of function stuff, because I was fine functionally. So in that particular case, that's I think a personal example of where the instrument did not fit what I was going through. We see this all the time though with patients. And like I mentioned before, I think many studies have actually looked at this, qualitative studies, where the tool really doesn't reflect the patient. One that'll resonate, I think, with the listeners the most is the sex question in the Oswestry, right? I mean, half the people don't even fill it out. They're like, what? None of your business, or yeah, I wish, right? And it's just not relevant to that particular individual. That's what we mean in some cases with these tools. They're just not really relevant to the individual. We have to capture something, and I don't mean to sound like a negative Nelly, but we have to capture something. But we need to recognize that what we're using to capture it is not perfect.
Sure. And it may even matter whether it's your right or left hand, right, Chad? So if it was function, if
Yep.
maybe it's your right dominant side versus, a left. And so that pain piece is really important for sure. So Chad, in this paper, what do you hope the readers walk away with after reading it and reflecting on your recommendations?
Yeah, probably the opposite of how I'm portraying myself, which is very negative. But I want readers to recognize that it's not a perfect, these things are not perfect tools, that they have error, they may not be relevant for the patient. There are some limitations. So there are going to be situations where you will see a meaningful change with your patient, but it may not be reflected in the tool. We have to use something to measure with our patients. And I would recommend using more than just one instrument, right? Most of the core outcomes of research suggest that you use more than one instrument, more than one construct to reflect that. But the takeaway from this, I think, is it's okay to recognize that there are some limitations with that. And it's okay to recognize that every now and then your patient's not going to be congruent to the tool they're using, and that outcomes measure is not going to tell your whole story. And the other thing is, your outcomes are going to be so heavily influenced by the type of people you work with. So if you work with people in high levels of social risk or individuals who are on workers' comp, you can expect those outcomes to be markedly influenced by those comorbidities or concomitant conditions. And that's something too that I think is a really important takeaway. You shouldn't be comparing a health status measure across particular populations and assume that the way you treat them is consistent, that outcome is going to be consistently altered by your intervention. There's just too many other things going on.
Great. So if you had 1 minute to summarize this paper with an insurance representative, what is it you would say?
With an insurance representative?
Yeah, let's go with an insurance rep.
Oh, that's awesome. I would tell them, I would try to convince them that there are challenges to trying to assume the care provided is completely reflected by an outcomes measure. I would suggest that if they're really interested in looking at value-based care, that you also look at what they've received for their intervention, the cost related to that, and what sort of care they received prior to that individual being treated. But also that the other things can influence that outcomes measure. So it's not a simple measure. It's not something whether they've met an MCID or not. It's way more complicated and way more challenging than that. And I would try to really reinforce that point to the individual.
Great. So Chad, in our wrapping up here, where should I guide our listeners to read more about the work that you do?
So on PubMed, certainly I do publish a good bit. So I think going to PubMed is a good spot for that. If you're interested in manual therapy, we do talk a lot about the research on our CMET website, which obviously if they're listening to this, they've already been on the website, so they see that. If you want to follow me, I'm on Twitter. I'm at Chad Cook PT, and I do tweet a good bit. So certainly there. And then pretty soon, we just received a fairly large NIH grant, and part of that grant will have dissemination. So it's a group called ForceNet, and it's a multidisciplinary group of PTs, chiros, biomechanists, imaging specialists, all of these folks working together, looking at manual therapy mechanisms and what they do, what they don't do, what to look for in these. And fairly soon we'll have a website and a social media dissemination platform for that. So you can see some of the work that we do there as well.
Well, excellent. Chad, thank you so much for taking the time just to hang out, answer all the questions that our listeners may have. And I'm sure you may have more questions for Chad. So don't hesitate to ping him in all of the ways that you can reach out to him, social media and Twitter, and check out that website and what all the wonderful things that we've put on CMMT. All right. Thanks, guys.